1 minute. Okay. So, as Kelly say, I'm a GI physician working since 2023 with Dr. Ines in the Celiac Clinic. And today I will be talking about a very important topic for many people living with celiac disease, that is persistent symptoms, and why don't I feel better? So, as we know, many patients are diagnosed with celiac disease. They start a gluten-free diet and expect to feel completely better. However, in many cases, as symptoms do improve, however, some people, symptoms could continue, or they improve at first and then the symptoms come back. So today, we want to try to help for our patients and the people that is present here to understand what is can happen and what the most causes are, and when it is important to seek further medical evaluation. So this is the agenda. So in this talk, I will try to focus on three main important points. First, we will review what usually happens after a celiac disease diagnosis and why some people continue to have symptoms even after starting a gluten-free diet. Second, we will talk about hidden gluten exposure, cross-contamination, and other causes of ongoing symptoms in treated celiac disease. And third, we will discuss when it is important to talk to your physician and what type of evaluation may be needed. So first of all, let me try to move to the basis. So as the vast majority of the patient knows, celiac disease is an autoimmune condition that is caused by immune reaction to gluten. This means that the immune system reacts in an abnormal way against the gluten. It could affect around 1 to 2% of the population. And it's important to say that gluten is a protein that most commonly is found in wheat, barley, and rye. And in people with celiac disease, usually what happens is eating gluten causes inflammation in the small intestine. Over time, this inflammation can damage the villi, as you can see in the image at the right. And this, of course, could lead to malabsorption of nutrients from the food. When the villi are damaged, the intestine may not absorb properly, and this could cause sometimes malabsorption. So moving forward and looking at the some of the prevalence and the epidemiology of the celiac disease, we can say that 30% of the general Caucasian population carries the genes for celiac disease, the HLA, the Q2, and the Q8. However, they could be also present in other populations, like in North Africa, in Middle East, South Asia, including India and Pakistan. So it is important to know that the celiac disease prevalence is increasing around the world in a similar proportion as in non-Caucasian populations too. More importantly, one of the reasons that celiac disease can be difficult to be diagnosed is that it can look very different in different patients. Some patients could have digestive symptoms. Some patients could have other symptoms that are not digestive at all: anemia, fatigue, bone problems, among others, or other symptoms outside the gut, right? So this is why the celiac disease is known as the chameleon. It could show and could behave as different in different patients. So only 30% of people, as I say, could manifest GI symptoms. And more commonly, nowadays, we are seeing more and more patients with symptoms that are not affecting the GI tract. So it is very difficult to identify celiac disease based only on symptoms. And we need, of course, to test to confirm the diagnosis. So celiac disease could be considered a systemic condition. It could affect the digestive system as could affect other systems and produce extraintestinal manifestation. So celiac could manifest with typical symptoms, digestive symptoms, symptoms that affect the liver, or also could be presented in patients with other manifestations like musculoskeletal in the skin, in the blood, sometimes also neurological manifestation and psychiatric manifestations. So this is very important because this also helps explain why some patients may continue to feel unwell even after starting a gluten-free diet. Sometimes the symptoms may relate, as I said, to the gut, but sometimes may be involved by other issues, for example, due to nutritional deficiencies uh, and, and other conditions. So moving forward, knowing about the clinic of celiac disease, how celiac disease could be diagnosed. So a correct diagnosis is very important because the treatment is a lifelong for, for the patients. So the diagnosis could include blood tests, could include, in many cases, an endoscopy with biopsies of the small intestine. And in some situations, also could include a genetic test that can also be helpful, especially to rule out the celiac disease when the diagnosis is uncertain. So one key point is that testing should be done while the person is still eating gluten. And if someone starts a gluten-free diet before testing, the results may become difficult to interpret. So as I said, the first step is to perform a blood test that is a celiac marker, a specific celiac marker that is called tissue transglutaminase as first line, which could show higher sensitivity and specificity. And usually we have to measure, of course, total IgA to rule out IgA deficiency. The second important step, as I mentioned, is to perform an endoscopy with biopsies. During endoscopy, what we do is take small samples from the small intestine to look for bilious atrophy, which means damage to the villi. Usually, this requires a good number of biopsies, and usually we recommend to take at least a minimum of 4 to 6 biopsies that are required to have a good amount of tissue in order to provide diagnosis or confirm diagnosis with the MASH classification. Another tool, as I mentioned, the HLA, usually is optional. It looks at the genes associated with celiac disease. It is especially useful when the diagnosis is unclear, when we have discrepancies between the blood work and the endoscopy. But this is very important because it's useful to exclude celiac disease. I mean, if HLA-DQ2 and HLA-DQ8 are both negative, celiac disease becomes very unlikely. And finally, of course, a response to a strict gluten-free diet can support the diagnosis. However, it should not be the only diagnostic criteria. The key message here, as I said, is that celiac disease is suspected better diagnosis requires being on a gluten-containing diet, and starting a gluten-free diet before testing can make the diagnosis difficult. So uh, now that we review what celiac disease is and how it is diagnosed, we can move to the next important question. So once someone is diagnosed with celiac disease, what is the treatment? And the treatment for the moment is a gluten-free diet. But the thing is, why, if I do in a gluten-free diet, could I still having symptoms? So once celiac disease is diagnosed, of course, this is the only treatment that we so far are recommending. At this time, the gluten-free diet is the only accepted treatment. And this means to remove the gluten from the wheat, the barley, the rye from the diet, and also avoiding foods that may contain hidden gluten or be contaminated with gluten. One important point is that even very small amounts of gluten can matter. For example, even research has shown that even around 50 milligrams of gluten per day, this means a few crumbs of breads, could be enough to prevent intestinal healing in some patients. So when we say strict gluten-free diet, we are not only talking about avoiding bread or pasta, we are also talking about avoiding repeated small exposures that may happen without the patient realizing it. So this is important because a strict gluten-free diet could lead to a better disease control, improvement of the enteropathy, and decreasing in complications. However, being on a strict gluten-free diet is not easy. There are some challenges of adopting a strict gluten-free diet. And a major problem is that a gluten-free diet is restrictive and it has the potential for adverse nutritional outcome, especially if adopted for a long term. Of course, patients on a gluten-free diet could be struggling financially. It is expensive, sometimes not covered, usually not covered. It could bring some alterations in quality of life, social challenges. It's not easy for some patients to eat outside home, at restaurants, to have social gatherings with friends, with the family sometimes. Of course, traveling could become an issue sometimes because they could not find gluten-free options in buffets, for example, in the hotels, to give you an example. It could be also, it could bring also nutritional imbalances. Gluten-free diet or gluten-free products usually are having different starches, different flours that are not enriched with the nutrients and the common flours with flours. And it could also provide, to provide palatability, it could also have a lot of sugars and fats. So that also could bring another complication that is seen lately is metabolic disease. So it is important to know also that patients are struggling with other situations they are trying to be on gluten-free diet when after being diagnosed with celiac. I mean, many clinicians, for example, may not have enough time, for example, sometimes to recommend or explain details of the food labels, ingredients, cross-contamination, about the restaurants, the cooking at home, nutritional balance. So this is why it's important the referral to a dietitian with experience in celiac disease. Also, to know that a skilled dietitian can help our patients to identify hidden sources of gluten, improve the quality of life, the quality of the gluten-free diet, and prevent nutritional deficiencies. It's also important to connect our patients with reliable celiac organizations because they can provide practical resources, community support, and updated information. So a gluten-free diet can be very effective, but it is also restrictive. If it is not well planned, can lead to nutritional imbalances, low fiber intake, as I say, excessive processed gluten-free foods, sometimes weight gain, and the metabolic problems. And as I mentioned, the access, the cost, and the availability could be a real barrier for a gluten-free diet, as lower income was an independent predictor of pure adherence, directly affecting health outcomes. Remember, gluten-free products are often much more expensive than regular products. In some studies, gluten-free foods cost more than twice as much on an average, and in some cases, even more, depending on the product. This is not a small detail. If gluten-free food is expensive or difficult to find, the adherence, as I say, becomes harder. So it has been seen that the cost of gluten-free products could be 400% more, and in 16% of celiac disease patients reported food insecurity negatively impacting in the adherence to the gluten-free diet. So when a patient struggles with a gluten-free diet, it does not always mean that they are not motivated. Sometimes the barriers are practical. They are because of cost, because of access, availability, social situation, or lack of support. This is why it's important to approach the patient with empathy, of course, and to support them. In addition, as you can see in this slide, This showed that some patients report intentionally eating gluten. This can happen for many reasons. For example, sometimes related to social pressure. Sometimes patients feel tired of restrictions. Sometimes they feel that small amount will not matter. Sometimes the diet becomes emotionally exhausting. And this does not mean that the patient does not care about their health. It reminds us that the gluten-free diet is a lifelong commitment and lifelong treatment that requires, as I say, support, education, and realistic strategies. So also now, even when patients are very motivated and believe that they are following the diet correctly, an intentional gluten exposure is common. This is one of the most important messages in this talk. I mean, studies have shown that many patients with celiac disease report accidental gluten exposure. And when researchers use objective tests like the GIPs, the gluten immunogenic peptides, in urine or stools, I will describe a little bit more in another slide about that. They often find evidence of gluten exposure even in patients who report good adherence. So this does not mean that the patient is telling me a lie. It means that the gluten can be hidden and cross-contamination can be difficult to detect sometimes. So if someone has persistent symptoms, one of the first things to investigate is not a rare disease or a bad issue or is that something wrong is happening. It's possible that the patient is having ongoing gluten exposure. So this is important to know where hidden gluten can show up. As I said, hidden gluten could be present when patients eat out in restaurants, buffet, cafeterias. Also, when patients are sharing another home appliances like a toaster, for example, or wooden boards or colanders, uh, or when they share sauces, seasonings, oats, of course, contaminated, unless they are certified gluten-free, processed foods, bulk beans, share scoops, transfer gluten between products, and label confusion. Sometimes it's important to remind that wheat-free is not gluten-free. And of course, some medications. Usually medications are safe. However, tablets and capsule fillers may contain wheat starch. So the key message is not that the patients should be afraid of everything. The key message is that when symptoms persist, these hidden sources should be reviewed carefully and systematically. So, having said all this is important to understand why the patients on a gluten-free could be on a gluten-free journey, and this could this is how can look like in the real life. I mean, at the beginning, many patients could start the gluten-free diet and doing a lot of efforts and having a lot of motivations and trying to do their best. But then real life situations happen. For example, eating at restaurants, family gatherings, eating at someone else's house, traveling, or relying on someone else to prepare the food. So even when a patient is educated and asks questions, cross-contamination can still happen. The message here is that the gluten-free diet is not only a list of food, it is a daily process of decision-making, communication, and risk reduction. So once the patients started a gluten-free diet, they have been diagnosed with celiac, of course, and after starting a gluten-free diet, many patients begin to feel better within the first few weeks or months. Digestive symptoms may improve, energy may improve, blood tests may start to normalize, but intestinal healing can take much longer. And in adults, studies have shown that complete healing of the small intestine may take months or even years, in some patients more than 2 years. So this is very important because feeling better does not always mean that the intestine has fully healed, and normal blood tests do not always guarantee complete healing either. So if symptoms continue after starting a gluten-free diet, it does not automatically mean the diet is failing. It may mean that the intestine is still recovering, that there is hidden gluten exposure, or that another condition is also contributing to symptoms. So this is why follow-up is important after the diagnosis. Okay, so now we arrive at one of the most common and important questions. So patients with celiac disease come to the clinic usually, and after the initial visit, starting a gluten-free diet, and happen that they are on 6 months, 1 year of gluten-free diet, and they say, I'm strictly gluten-free. However, I still feeling symptoms. I still have symptoms. What should I do? So the first answer, of course, is talk to your doctor. Persistent symptoms after a gluten-free diet are common, and they deserve proper evaluation. Patients should not feel uh, dismissed or told that this is nothing, is not happening, that you are having a problem. No, this is something important to be assessed. And at the same time, persistent symptoms do not automatically mean refractory celiac disease or something severe. There are many possible explanations, and most of them can be investigated step by step. The goal is to find the reason behind the symptoms, protect your intestinal health, improve your quality of life. So if symptoms persist, the best next is not to panic, but to seek proper medical counseling and nutritional evaluation. So we have seen that the gluten-free diet is effective, but it's complex. We have also seen that hidden gluten exposure is common, even in motivated patients. Now we are going to discuss a specific concept that is non-responsive celiac disease, what it means, how is it evaluated, and what possible causes should be considered. So non-responsive celiac disease, NRCD, usually this term is used when a person with celiac continues to have symptoms, abnormal blood tests, or intestinal changes despite being on a gluten-free diet at least 6 to 12 months. There are two main situations. Usually the first one is called primary NRCD or non-responsive celiac disease. This means that symptoms never really improved after starting a gluten-free diet. And the second one is the secondary NRCD, is when, in this case, the patient initially felt better, but after some time, symptoms came back. And this is important because the distinction is useful because it helps the doctor understanding the clinical pattern. But the most important message is non-responsive celiac disease doesn't mean to be something bad again or refractory celiac disease. We've seen sometimes a lot of patients that are referred to the clinic that when they started to have persistent symptoms are labeled like refractory celiac disease. And this is not usually the case. So NRCD, non-responsive celiac disease, is much more common. And in many cases, the cause is, as I said, hidden gluten exposure, some other conditions that I will summarize later. And the evaluation should be systematic. We usually start by confirming the original diagnosis, reviewing the diet carefully, and of course, if necessary, repeat some tests. So even well-motivated patients are frequently exposed, finding and eliminating the source result symptoms in most cases, and in 83% of the cases, improve after gluten elimination. So as I say, it's very important to review and confirm the diagnosis of celiac disease. A person or a patient that comes to the clinic may follow a strict gluten-free diet for years, so we want to make sure the diagnosis was based on reliable tests. This means reviewing the original blood tests, biopsies, sometimes the HLA if patient have them, It is important to remind not all blood markers perform the same way. Some tests are more accurate than others, and some results can be difficult to interpret if the patient had already started a gluten-free diet before testing. So these uh, these celiac markers usually were the ones that we uh, were using before, the anti-gliadin antibodies. However, due to their low sensitivity and low specificity, they have been falling in disuse. And nowadays, we are using another antibodies and more specific celiac markers in order to help diagnosing the celiac disease. So when symptoms persist, we should not immediately assume that the gluten-free diet is failing. First, we need to make sure that the original diagnosis is correct. Another thing is, as this slide shows, other conditions can cause inflammation or damage in the small intestine and may sometimes be confused with celiac disease. For example, where I can summarize all of them, but most importantly, there are some more frequent conditions that could affect the small intestine in a 10 to 30%, like autoimmune enteropathy, collagenous sprue, or IBD that coexist also with celiac disease. Um, and this is especially relevant because if the original diagnosis was made without a biopsy, incomplete in test, or after the person had already started a gluten-free diet, we need to also seek for other, beside confirming diagnosis, look for other causes that could resemble enteropathy in the patient. Also, there are some other causes. For example, in some patients, we could see some peptic duodenitis in a 16%, and patients that usually take NSAIDs that could produce also this enteropathy and inflammation in the gut. So the goal is not to create doubt in every patient. The goal is to make sure that each patient has the right diagnosis and therefore the right management plan. However, if we have some doubts and the patient has some doubts about their celiac diagnosis, if there are concerns about that, we could repeat the test. This may include repeating serology, such as TTG, DGP antibodies, doing or repeating an upper endoscopy with proper number of biopsies, and sometimes, of course, checking the HLA, the genetic test, in cases that we have before discrepancy in the previous investigations. However, there is one key point here that these tests are most useful when patients are eating gluten. However, if someone has already been on gluten-free diet for several years or several months, the blood tests, the biopsies may look normal, even in person who truly has celiac disease. So in some cases, a gluten challenge could be needed, but this should always be discussed with the patients. It is not something that patients should or desire to start on their own. And of course, it's because sometimes patients, when they get again exposed to gluten, they become very symptomatic. So the message here is, if the diagnosis is uncertain, it's important to talk with our patients before making any decision and before making changes or embarking them on several tests. Another thing that we have to do is explore causes of non-responsive celiac disease and other causes. So once we have reviewed the diagnosis and assessed possible gluten exposure, we also need to consider other causes of symptoms. This is because symptoms like, I don't know, bloating, abdominal pain, diarrhea, constipation, fatigue, discomfort, sometimes could be not related with celiac. And they can also be related with other conditions, like, for example, uh, as I summarize here. So the evaluation is like a map. We start with the most common and most likely explanation, and then move step by step depending on the patient's symptoms, history, blood tests, and response to treatment. So, doing more practical overview on this regard, we can say that usually gluten exposure or hidden accidental exposure is the most common cause usually that we find in our patients, more than 80%. And this is important because it's important to assess the patient with a dietitian and sometimes with other tests that they can do like a chip test. Another condition that we have to, of course, take in consideration is irritable bowel syndrome. It's very common. Usually, symptoms of IBS are characterized by abdominal pain, sometimes followed by diarrhea or constipation or bloating or gas. There is no test available for this. It's only a clinical or symptom-based diagnosis. And we can treat the patients according to their symptoms and see how the patient responds to treatment. Other conditions that sometimes we found in our patients is some food intolerance, like lactose intolerance or FODMAP intolerance. They are common. There are some tests that could for lactose intolerance, but it's usually not offered. Usually, these intolerances are assessed by interrogatory of the patient, seeking some possible food triggers to symptoms. And sometimes we can recommend empirical lactose elimination when we suspect lactose intolerance, or sometimes we can do a low FODMAP diet or low FODMAP diet trial with, of course, always assessed by a dietitian in selected cases. Other causes that we have to take in consideration, small intestinal bacterial overgrowth, SIBO. This is usually the migration of our colonic bacteria to our small intestine. This could be common. There are tests that were offered before, currently are not. And usually one approach is to perform an empirical treatment and in order to see if the patient has response to it. Another condition that we usually could see in some patients, less commonly, but is seen in some of the patients, is a microscopic colitis. Usually, colonoscopy with random microscopic biopsies allow us to diagnose this, as, of course, other conditions that could behave with diarrhea. Also, in microscopic colitis, patients could manifest with a lot of diarrhea. So, pancreatic insufficiency, another condition that could coexist with celiac disease are inflammatory bowel disease. So we can assess the patients with this, with colonoscopy, with stool tests like fecal elastase or fecal calprotectin plus colonoscopy. And finally, as you can see, after we rule out or we consider that these are not the causes of the symptoms of the patients, finally is the refractory celiac disease, which again is rare, less than 2%. But if we suspect it, we diagnose it, it's important to refer our patients to a specialist and third level facility for follow-up and possible treatment. So moving forward, it's important to talk about, I will talk a little bit, a few words about chips and detecting hidden gluten. As I mentioned before, hidden gluten is the most common cause. So here is where the assessment with the dietitian, of course, the gluten immunogenic peptide could have an important role. These are fragments of gluten proteins that survive indigestion. They could be detected in urine and stools. They have been validated by research studies and can help distinguish between non-responsive celiac disease from true refractory celiac disease. Usually, it's more accurate to use the stool test because it has been seen that the time window in order to see or detect gluten, it has been more prolonged than in the urine, 1 to 5 days, and is much better for monitoring if patients can be exposed to gluten. I mean, to give you an example, if we have patients with persistent symptoms and we assess them to check if there are possible gluten hidden sources, one of the options is the patients to acquire these tests, and they can do it at home. And for example, after in a weekend, after they eat in a restaurant, they can try this test at home through a stool test in the in the te- in the through these chips. And then if they have a positivity in this test, they can see that they were exposed to gluten. So in most cases, chips perform better at detecting gluten exposure than all other available tools to assess gluten-free diet adherence. And chip urine testing identified gluten exposure in patients previously, though to have refractory celiac disease, changing the diagnosis to more non-responsive. So I think this is very important when we have patients with persistent symptoms to discuss with them, assess, and advise with this. Another thing I mentioned is the FODMAPs. And we can say that the low FODMAP diet or low FODMAP gluten-free diet has been studied in patients with celiac disease who continue to have symptoms. We can say that FODMAPs, first of all, is a group of carbohydrates. It can be difficult to digest or absorb in some people. They are not gluten. This is important to differentiate. A patient may be completely gluten-free and still have symptoms because, for example, FODMAP intolerance. FODMAPs can be found in many foods like fruits, vegetables, dairy products, legumes, wheat-based products, and sweeteners. And in people who are sensitive to them, of course, the FODMAPs, what can produce is pulling water into the intestine and can also be fermented by bacteria in the gut. So that's the reason why these FODMAPs produce the symptoms of diarrhea, gas production, bloating, distension, flatulence, sometimes constipation, abdominal pain. And this can, so in many patients, the problem is not ongoing gluten exposure sometimes, but another digestive desensitivity that is producing very similar symptoms. As I said, a low FODMAP diet has been efficacy, and this has been demonstrated through the research. As you can see, 4 studies, 2 randomized controlled trials, 2 open label studies, comparing a low FODMAP gluten-free diet to a regular gluten-free diet in 150 celiac disease patients with persistent symptoms. And they found that a low FODMAP gluten-free diet for a minimum of 4 weeks was more effective than regular gluten-free diet in reducing symptoms. However, don't forget that patients are already on a strict gluten-free diet, on a restricted diet, so we have to be careful because it's also restricting some other nutrients like fiber. So it's important the guidance by a specialized dietitian, which is key in managing these restrictive diets. And then now that I talk already about all the possible causes of persistent symptoms, I mean, I talk about hidden gluten or possible gluten exposure or accidental gluten exposure. I talk about the possible causes of persistent symptoms. And then we reach the part that is important also to mention. I mean, it's not for alarming the patients, but we have to mention that it could be seen in some of them. So refractory celiac disease, what it is? Usually it's characterized by persistent or recurrent symptoms and signs of malabsorption with a small intestinal bilious atrophy, and most likely is negative celiac disease serology. This is important because some patients that were labeled as refractory usually have positive celiac disease serology. And this is usually related with gluten exposure. So this usually is not refractory celiac disease. And this is despite a strict gluten-free diet for more than 12 months. It's important to know that it's rare, as I say, affecting 1 to 2% of the patients with celiac disease and 10 to 15% of non-responsive celiac disease. Usually, we can divide them in two types, type 1 and type 2. Type 1 is the one that has better prognosis, the one that is uh, less severe. It is characterized by no changes in cells identified by immunostaining. Has for it has for sure less risk of complication when we compare with the type 2 RCD. In the other hand, the RCD type 2 is the one that it could behave with changes in cells identified by immunostaining with higher risk of complications. Let's say ulcerative ileitis or lymphoma. So when we found a patient, we have a patient with these features, it is important strict and close monitoring and follow-up with repeating duodenal and jejunal biopsies, immunostaining of intraepithelial lymphocytes to see the phenotype, to check the whole small intestine through another test, like a capsule endoscopy, and even though with other tests, maybe no invasive tests like a MRI enterography or CT enterography. This is important, as I said, because the refractory celiac disease could have 5 year survival, the type 2, most importantly, of 50%. However, it could be treatable, as some patients could respond very well with a strict gluten-free diet or elemental diet. Some patients could respond very well to corticosteroid treatment and immunosuppressants. So coming to the end of the talk, and just because I don't want to overwhelm the patients and all the attendings, I would try to remind you with a nice algorithm I found what to do usually in adult patients with celiac disease and persistent symptoms despite being on a gluten-free diet. So usually we have to review the original celiac disease diagnosis, review the serology, the biopsies, a diagnosis, if available, review the HLA status. Then, if the initial diagnosis was doubtful, so we can say we have to reevaluate the celiac disease if needed, including a gluten challenge. And if we found that it's not celiac, we'll consider an alternative diagnosis. Then let's suppose that the initial diagnosis of celiac disease has been well documented. So we have to assess the patient with a dietitian, interview, possibly with chips, for a very good dietary revision, maybe performing serological tests. And then if we found what happened with the gluten contamination, is there gluten contamination? So the persistent symptoms are due to gluten ingestion. Again, in the 80% or more of the patient is what we found. So here is where eliminate gluten and strict follow-up is important. However, what happens if we don't find any gluten contamination? So there has been no dietary indiscretion. So again, we have to recheck the bowel, make again an endoscopy, take duodenal biopsies with flow cytometry if necessary. Before that, we can check also for non-gluten related causes, as I said, IBS-like symptoms, microscopic colitis, pancreatic insufficiency, like some other food intolerance. However, if all that checked, that was checked, and then we perform an endoscopy and even the endoscopy didn't show any bilious atrophy, of course, usually this is related with functional symptoms or other causes. However, if we found some bilious atrophy, persistent bilious atrophy, after 12 months of gluten-free diet with aberrant T cells but less than 20%, we have to consider that this could be a patient with slow response to celiac disease, to gluten-free diet, or refractory celiac disease type 1. In the other hand, if we found bilious atrophy persistent with aberrant T cells more than 20%, we have to be aware that we are in front of a RCD type 2 and further workup is needed, as I said before. Remember, RCD type 2 should be managed in expert centers, so through a close monitor and follow-up. Another thing I want to bring up is some common myths and facts. So it's important to mention that if I still have symptoms, I must have refractory celiac disease. No. Non-responsive celiac disease is far more common, 30 to 40%. The most likely cause is hidden gluten, which is usually fixable. My TTG IgA is normal, so my intestine must be healed. Again, blood tests can normalize before the gut is fully healed. Normal serology does not always mean normal biopsy. I have been gluten-free for years, so I can still be getting exposed. Research using GIP testing confirmed ongoing exposures in long-term patients who report perfect adherence. And all my symptoms might be from gluten. Nothing else explains them. IBS, lactose intolerance, SIBO, other conditions could explain your symptoms, are very common in celiac disease patients and cause identical symptoms. So finally, some key messages to take home. First, persistent symptoms after a gluten-free diet are common. You are not alone, and they deserve evaluation, not dismissal. Hidden gluten exposure, often unintentional, is the most common reason. A celiac specialized dietitian and SHIP testing can help find it. Other conditions, IBS, SIBO, lactose intolerance, among others, frequently could cause identical symptoms and should be investigated. Refractory celiac disease is rare, less than 2%. It requires biopsy proof and specialist evaluation. And finally, the goal is always to find a reason, protect your health, and improve your quality of life. Thank you very much.
Thank you so much. That was so informative. I'm gonna have to watch that again because that was jam-packed with information. Thank you so much for sharing all of your knowledge with us. We do have quite a bit of questions.
I cannot see.
Dr. Inez is joining us. Lots of people say thank you so much. I agree. It was such an informative session, so thank you. I think, I will go through the questions and then whoever wants to answer them can. We have, under 10 minutes, so we'll try to get through the most common ones. Let me just see here. First, people asked about the GIP testing. So, are there home gluten detection kits available, reliable? Are they clinically useful? Can they buy them?
Uh, can I answer that? Maybe Ines have another options, but as I know, they are not still available in Canada. As I'm aware of that the gluten detect kits are only available in the USA. They could be acquired through the official webpage. However, it has a cost, but it comes in a box with I think three cases, and I think I think it's very useful for the patients when they persist with symptoms and we are not sure if they have hidden gluten possible potential hidden gluten exposure from there.
Mm.
Just to add on that, gluten gluten immunogenic peptides in stool and better than urine detection kits are very reliable. There
Yeah.
are multiple studies that have been published. There are, like more than 18 studies that the last systematic review that found. So they're very accurately detecting gluten in stool. Stool is better than the urine because it detects gluten for like around 3, 4, up to 5 days, depending on the person's transit time. The urine is a little bit is a reliable test, but it's a shorter period, so it only lasts less than a day, like hours. So if there is a suspicious of a very immediate, like within hours, to gluten, then the urine is better. But what we recommend is a stool because it can detect it after 3, 4, 5 days. And as Dr. Francisco says, these tests are usually available in the US. There is, I think, one company that is in Canada that I just realized someone posted a question and gave a commercial name. I have requested to contact with the rep, but I have no experience using that specific test.
Okay, thank you. Are they coming to Canada or is
So
that?
the company, the Gluten Detect, I'm not sure that they're coming to
Mm,
Canada. The other company that someone mentioned, the Gluten Talks, is apparently is in Canada, but I have to
okay.
verify with them.
Okay, interesting. Another common theme was about healing and recovery. So once the villi are damaged, can they recover and how long does healing usually take?
Ines or me? Okay.
So so usually it takes in children is faster. It takes a year or two. In adults, most of the time, 60% of people or more, based on the studies, take 2 years at least. And in our experience, sometimes it takes longer. But then this is highly dependent, of course, on the person's ability to heal, but also the exposure, right, to gluten. Sometimes the first year is very challenging because everyone is learning how to avoid gluten, and accidental exposure happens more frequently
Yeah.
during the first year. So it's very, very unlikely that you will have healing in the first year. It takes 2 years at least in adults.
And what about persistent elevated blood levels or TTG levels? So someone said their TTG was trending downwards, but then recently increased despite being extremely careful. So are these fluctuations normal?
Well, I assume that sometimes, usually, when we see increasing in the, or again in the antibodies for celiac, usually could be related with hidden gluten exposures or unperceived sometimes. Sometimes we have patients that they say that they are doing a very, very strict gluten-free diet and they still shows in blood work some mild trace elevated of TTG, for example, at 5 or 6. Sometimes it's not always related with cilia, as I mentioned. Sometimes there are other conditions or autoimmune enteropathy or other conditions that could be also, like, for example, patients with type 1 diabetes could show also some increasing or mild increase in the celiac antibodies.
Yeah. So the great majority are inadvertent gluten exposure, something that people cannot identify, and that's why it's so important. We work very close with our dietitian Jadid, and every time that we face these situations, we ask Jadid to spend significant amount of time in reviewing everything, right? So, and sometimes they identify situations that there could be hidden gluten or contamination, or and sometimes we can't. And as Dr. Francisco says, many times there are other causes for the TTG, but the great majority are hidden gluten.
Yeah.
Yeah, and I think again that's why it's so important to go see a dietitian that specializes in celiac disease. Um, what about if someone is asymptomatic? Someone asked, how would they know if they were accidentally exposed?
Do you want me to ask? Okay, so if someone is asymptomatic, of course, we cannot rely on symptoms. However,
Mhm.
if someone is symptomatic, we cannot rely on symptoms either, because not all symptoms are gluten.
Mhm.
There are people without celiac that develop symptoms after even going out, dining out. So you cannot always confirm based on symptoms. But if you're asymptomatic, that's even more challenging. So that's why what is recommended is to monitor with TTG regularly. So these celiac markers in blood. So that can be done with your family doctor or with your gastroenterologist. If the celiac is like is perfectly well controlled, is once every year or every 2 years. If the celiac is still active, is every six months around that time. Sometimes it's 6 to 9 months. And so then is to monitor that and make sure that the celiac activity based on the immune activity based on the blood work is coming down. The other way of detecting that, if you suspect for some other reason that you was exposed to gluten, is to do those gluten detect tests in the stool mostly. So do those detectors, the gluten immunogenic peptides in stool. So that's another way of confirming if you was exposed to gluten, if you have highly suspicious that happened.
Yeah, I think also that's why follow-up care is so important. And I think sometimes it gets neglected, but yeah, it is really important, and the blood work and sometimes repeat biopsies possibly. But definitely talk to your clinician and see a registered dietitian too. They will help. Maybe we'll do one more. I know we're a little bit over time.
Kelly, I want to clarify when I say TTG is for people who develop IgA. There are some people that they have IgA
Yeah.
deficiency and they have
Mm.
other markers like DGP.
I think there was a question related with that, yes, in the chat.
Let me see. There's so many. I want to do one that is
Thank you for
common.
asking so many very interesting
Yeah.
Yeah.
questions. That's amazing. I love when people participate.
Um, I think we've talked about healing timelines. Can celiac, oh, some people have asked about like late onset and seronegative celiac disease. Can celiac disease develop later in life, even in people who previously thought they just had IBS? And
Yeah.
what about situations where genetic testing is negative, but celiac disease is still suspected?
Well, I mean, we have seen patients with diagnosis of celiac in 50, 60, 70 years, right?
Mm.
So celiac could, of course, manifest earlier in the lifetime or in the mid age or in more advanced age. Um, and the other thing, sorry, the other question was
The last part of it was, what about situations where
is
genetic
HLA.
testing is negative, but
Yeah.
celiac disease is still suspected?
Well, usually if patients with HLA, if the HLA, the DQ2, the DQ8, and now we have another one that is permissive, that is HLA DQ7, if they are negative, it's very unlikely that the celiac disease will develop in that patient because they are not carrying the genes that could predispose to develop the disease. And
Mm.
maybe the symptoms are not related with celiac, are related with other conditions that is not celiac, or very unlikely that is because of celiac disease.
And then you can do endoscopy, right? So if
Right.
highly suspected, you can do endoscopy and see.
Exactly.
And there are what is called seronegative celiac, so around 5% of people with celiac disease that they do have the gut inflammation,
Yeah.
they don't develop these antibodies, either the TTG or DGP. It's very rare, it's kind of less than 10%. So, but still, it can happen. So if there is highly suspicious, it's still doing endoscopy. And as Dr. Francisco said, the genetic.
Okay. Well, I think We're 5 minutes over. I think, I see so many comments in here saying that it was such a valuable session and they've learned so much. And I can say the same. It was so informative. I think we'll definitely have to have this again because there's just so much information and there's so many situations that people go through. Again, care is so individualized too. So I hope we helped answer a lot of people's questions. And again, this is recorded, so watch for the email.